anesthetist. Um, so I'm excited to talk to you guys a little bit about nurse anesthesia, what it is, what it entails, what the path to get there, um, is like. When I was in nursing school, I felt like most of our classes were taught by APRNs. Never once in my 4 years of nursing did anybody ever talk to me about nurse anesthesia, or was it ever brought up. And I feel like there is a gap in knowledge about what it is, what we do. Excuse me one second, Maeve. You have to stop, honey. Sorry, I have my 3-year-old with me as well, who is making a whole bunch of noise. Um, but yeah. So this is me. This is my graduation. I graduated from the Yale New Haven Hospital School of Nurse Anesthesia in 2023, May of 2023. And then just a little bit about me. I'm a mom of 2 girls. Maeve is on the left. She's my 3-year-old, and McKenna is my little one. She's 14 months. Outside of work, I enjoy, working out, being outside, the beach, and all of those fun things. So what is nurse anesthesia? We are advanced practice registered nurses here in Connecticut. It does differ by state. I know in New York, you're not required to have an APRN license, you just work under your RN license. So it just depends on what state you're in. But here in Connecticut, we are advanced practice registered nurses. It's an additional 3 years after nursing school. Throughout the United States, we administer 50 million anesthetics per year. And nurse anesthetists are actually the main anesthesia providers in much of rural America. Most of the middle of the country is actually all CRNAs, a lot of CRNA only practices. And then as well as the US military. So nurse anesthetists have independent practice in all of the branches of the military. And that's, like US based and foreign based. And then we practice in 22 states and in Guam without physician supervision. There's a big push for what we call opt-out states. And this basically means that the governor petitions that he wants nurse anesthetists to be able to opt out of certain Medicare and Medicaid criteria. So it's all really based on insurance, which is a whole complicated process, but basically it allows nurse anesthetists to practice in many more areas independently. And there's a multitude of reasons for this. Much of the middle of the country where it's quite rural, there's just no physician anesthesiologists. Big cities always, are going to draw physicians. That's where, academia is, research is. And so they flock to areas like where we are, here in Connecticut, Boston, New York, those kinds of areas. But there's many parts of the rural parts of the country that don't have even an anesthesiologist inside that county. So this is where nurse anesthetists come into play a huge role in providing care for millions of people, especially in some of these underprivileged areas or rural areas. Nurse anesthetists are the main providers in critical access hospitals, which are, incredibly important, usually small rural hospitals. So what do we do as nurse anesthetists? Basically everything. We are responsible for doing all of the preoperative assessments. So this can be anywhere from determining if a patient needs EKGs and lab work, or cardiology clearance, physician, primary care clearance before surgery, to seeing your patient the morning of surgery, making sure they held the right medications, took the right medications that they were supposed to take for that day, assessing their airway and what you think your management is still appropriate after you actually see the patient in person. And that, plays into our anesthetic planning. In terms of anesthetic planning, it's making sure that the anesthesia you're giving is matching the surgery type you're doing. So there's some, procedures that you can do under light sedation, or, what people refer to as twilight. And this is kind of just, sedation. It's patients don't need their airway augmented. They just breathe on their own, and just kind of keep them sleepy, and, so they don't remember the procedure. And this goes all the way up to planning for general anesthetics, where the patient needs full intubation and, a breathing tube and paralysis in order for the surgery to be completed. So a lot of what we do is working with our surgeons to make sure that we are giving them what they need for the surgery. And then looking at our patients and their comorbidities and determining what is safest for them. And May, you have to stop. You need to take that out. Okay, I'm so sorry about the noise. So, a lot of it's looking at the whole picture of what we are doing. And then we do a lot of skill-based procedures. We're responsible for intubation during surgery, as well as we respond to, cardiac arrests throughout the hospital. We respond to traumas in the emergency department. So, a lot of times I will end up going to, can you guys hear me?
Yes.
Okay, I just saw a comment that said, I can't even hear.
Yes.
I just wanted to make sure.
We can hear you. We also can't hear your daughter too much, if that
Okay, yeah, no, I'm so
helps.
sorry. She is, very eager to hang out with me for some reason tonight. But yeah, sorry. So back to what I was saying. And then we do other skill-based procedures. We insert RIVs during surgery. We insert arterial lines, central lines, Swan-Gaines catheters, all of those, depending on what kind of surgery you're doing. A lot of what we do is also we're responsible for spinal and epidural anesthesia. So we spend a lot of time, I personally spend a lot of time up in labor and delivery, where, spinals and epidurals are used as the primary anesthetic, as well as providing them for other surgeries like total joint replacements, and anything else that would warrant it. Nurse anesthetists also do regional anesthesia. These are nerve blocks that are usually given before surgery to help with post-operative pain. These procedures can be done pre-op or post-op. Sometimes we even do them intraoperatively, depending on what the surgery is and what's going on. The hospital I work at, so I work at St. Vincent's in Bridgeport, and we just instituted a program where we preventatively block hip fractures. So when they come into the emergency department, the ortho PA will call us, we'll go downstairs, block the patient before surgery in the emergency department. And sometimes they don't go to surgery for 24 hours or, around 24 hours later. But this helps control their pain during that 24-hour window, and minimize narcotic use, which is important in these elderly patients who often end up delirious and confused, and all of the other issues that go with your opioids. And then we also are responsible for post-operative monitoring. So we respond to everything in the recovery room. Our nurses come to us for, the patient needs more pain meds, the patient's having nausea. So we also monitor all of that, make sure our patient stays safe through that period. And that tends to be more of like a, a group project. Whoever's free kind of gets that job, whoever's not in the operating room. So the path to becoming a CRNA, So the first is having a baccalaureate degree in nursing. And then you obviously have to achieve licensure as an RN. Most programs require about 18 months now of critical care experience. 1 year to 18 months is the average for that. And then the nurse anesthesia program is a 36-month doctoral program. And it usually comes out with 2 degree paths, either a doctor of nursing practice or a doctor of nurse anesthesia practice. So my degree is a DNAP degree, and all it really means is that my anesthesia program was housed in the School of Biology, where a DNP, a doctor of nursing practice, was their program is in the School of Nursing. So like Fairfield University is a DNP program. So, kind of my pathway, I did a traditional 4-year nursing program, and I went to the ICU as a new grad. So I went to the medical ICU at Yale New Haven Hospital. And I was there for about 18 months before I applied to school. And then by the time I actually started school, it was like closer to 3 years. Going into school, I had about 3 years of experience. And then I started my anesthesia training in May of 2020. So kind of right as the pandemic hit, which, made for interesting times. But nonetheless, we were lucky to graduate on time and have no issues with that. So just a little bit about our training and education. This is kind of a comparison between the pathway to become a CRNA or a physician anesthesiologist, and I'll talk a little bit about the differences. So, you need your 4-year undergraduate degree in to apply for school. So that would, is your first 4 years, minimum of 1 year of critical care experience, but I believe the average is about 4.5. So most students going back to school are, kind of in their late 20s, early 30s is where the average falls. And then it's 36 months of anesthesia training, compared to a physician anesthesiologist. I mean, granted, they do their 4 years of undergraduate, but that can be in anything. It's not medical training. They do 4 years of med school, and then they have their 4 years of anesthesia residency. So, nurse anesthetists, the programs average anywhere from 21 to 51 months. I think the average is about 36, throughout the country. As of 2025, all nurse anesthetists graduating have to be doctorally prepared. So any like master's programs that are left either have to convert to a doctoral degree or close. And then by the end of training, the average amount of, the average clinical time nurse anesthetists have is about 13,000 hours. And, the big difference here is that we go into anesthesia training with critical care experience. You already know how to do all of your basic skills, IVs, inserting, nasogastric or oral gastric tubes. You've assisted in intubations, you've assisted in, central line placements, 8-line placement. So there's, so much experience that's gained through that. And then a lot of the medications you use are very, very similar. And then in terms of like what can you do after anesthesia school, there are a couple programs throughout the United States that offer fellowships, and these are a year to 2 years of specialty training, where you really hone in on one area. So there's some programs for regional anesthesia and some programs for pediatric anesthesia. That being said, you don't need a fellowship to perform in those, aspects of nurse anesthesia. So I wanted to leave lots of time to talk about, questions you have, how I got here, whatever you guys really want to hear about.
Hey Shay,
Yeah,
hi, it's Kaylee. I was just, can you see the chat in here? I didn't
I
know if it
can,
popped.
yep. I'm just
Okay,
opening it now.
I wasn't sure if it pops up for you because I saw like people asking a couple questions, so I didn't want you to get pushed off topic there. If it's easier for you to do questions when, questions. Oh my
Perfect.
gosh.
Yeah, I'll start with question. I'll start at the top of the list then. Yeah, so the difference between a nurse anesthetist and a physician anesthesiologist is somewhat dependent on what state you're in. In Connecticut, we work under physician supervision, which means we do not work independently. Though where you work, that'll like what that means will vary greatly. I work for a wonderful practice where I have tons of autonomy. I do all of my own cases, make all of my own decisions. And our physicians are kind of just there if you need them. They support us, they help us, but they're not super aggressive in terms of like controlling you and what you do. That's not the case everywhere. So you definitely have to decide what you want. The physician, in Connecticut, a physician anesthesiologist obviously can do everything we can do and practice independently. We are working, I think as of last year, we had petitioned to Department of Public Health for a scope of practice review. And we are trying to take steps to independent practice in Connecticut. In other states where CRNAs do have independent practice, there's absolutely no difference between a physician anesthesiologist and a nurse anesthetist. They work exactly the same and essentially perform the same functions. Nurse anesthesia school is 3 years full time. It is a very big commitment. Your first year to year and a half is front loaded with your coursework. So you do a lot of your classroom stuff right up front. That's all your core math, sciences, and all of that stuff. And then your last 2 years are spent full-time clinical. So you're in the operating room anywhere from like 40 to 60 hours per week. So it is full-time. There are not options at this time for a part-time track, which is, a little unfortunate, but it is a big commitment. How important is your undergrad GPA? So this is somewhat dependent on the program you're applying to, and I think you as a person. The minimum requirement is usually like a 3.4 in your sciences, so like a B average in your science, your science courses, which you can apply with. I think also being involved in other things outside of just school is also important. They like to see that you have hobbies, interests, that you were part of organizations and nursing organizations, and kind of like extracurricular activities, if you will. And just all around like a well-rounded student. And then they also really value that you have support going through a program like this. You do make a lot of sacrifices and you do give up a lot of time to go to school. So they want to know that your family supports you in what you're doing. But grades are important. They do have minimum requirements, but they're in the end not the only factor they consider. What do you wish you knew before CRNA school? I'm going to come back to that one. I can't think of anything at the moment. Actually, that's not true. I wish I knew about all of the endless possibilities of what you can do with a CRNA degree. There's lots of CRNAs who work independently to do fun things like aesthetics. They do Botox and stuff like that, which I think is really, really cool. Because we work with needles and patient care so much that CRNAs tend to be really good at these procedures. I also wish I knew how much fun it was. School is really stressful, and you kind of get stuck in this tunnel of just constantly doing work and being stressed out about school. But day to day, like I actually really enjoy my job. I take call, so I'm 24 hours in the hospital once a week. And so it's really fun. I get to see really cool things, do really awesome cases, really difficult cases, and it challenges me, and it's fun. Were you able to work while doing it? So most programs highly discourage you from working. I did work part-time during my first year. However, I did have the advantage that our classes were online at that time. If they were not, I think that might have changed things a little bit. But some programs make you sign like a contract that says you will not work. My program did not. They just highly discourage you from working. What did you enjoy most and what did you not like the most while you were in school, clinicals and otherwise? The cool thing about school is that you get to do like the hardest case of the day. So if there's something cool going on, they'll pull you out of like a normal operating room and they'll put you into these cool cases, big heart cases, big, cranie cases. And so that was like a really awesome part of school because you always got to do those good cases. What didn't I like? It's definitely a huge sacrifice. It was a lot of time away from my daughter, and my husband. It's stressful. So those are definitely the cons to it. Any comments on how you feel about your current autonomy or lack thereof? So like I said before, I work for a really awesome group who lets us have a lot of autonomy. They're there to support us, but I tend to, have a ton of autonomy, especially because I take call. So a lot of times when I respond to codes, or cardiac arrests or traumas in the emergency department, nobody goes with me. I can call for help if I need it, but 99.9% of the time I'm the only one responding. So, those situations you really get good at, trusting your gut and your clinical assessments. But in terms of autonomy, I definitely feel like the group I work for allows us to have it, which is really nice. And that's part of why I chose the group I work for, because that was an important thing to me. What is your work schedule? How many hours a week do you work? Are weekends and holidays required? So that's the awesome thing about nurse anesthesia, is that you can work anything you want. So I currently work a 24 and 2 8-hour days because that's what works for our schedule right now. My husband is a firefighter, so he works 2 24s. We alternate our days. We don't pay for childcare because somebody's always home with them. So that being said, you also have the option to do things like 410s or 312s. Kind of whatever you want. Work depends on the group you work for and whatnot. But the possibilities are endless. I have a requirement to do some weekends and holidays because of my call requirement, but our CRNAs who don't take call have no requirements. So they they just work a normal schedule. They either work 410s or 5/8s or something like that. Please stop. And so they have no weekend or holiday requirements. Let's see. Are you allowed to act as an independent provider where you can write your own orders if an RN needs it. Yes. So, I write all of my own orders. I order all of my meds for PACU. And then if my patient needs something in the recovery room, or is having airway issues, having other issues, I am happy to always go assess them and take care of it. So yeah, we write all of our own orders. Somebody asked, you never worked while getting the degree. I worked for some of my first year, I worked part-time. And then I left, about at the end of my first year, because clinical became more demanding at that time and I had less flexibility. How is the classroom workload compared to clinical? So classroom and clinical are super different. The classroom is really rigorous in the sense that I would say you have like 2 or 3 exams every single week. You're constantly studying, constantly doing work. And that's the demanding part there. Once you make that transition into clinical, I would say like your life improves dramatically because there's much less testing, a lot less studying at home, but your focus also shifts because now the night before you're preparing for your cases in the OR the next day, which sometimes is, surgeries you've never heard of, or patients have these wild comorbidities that you've never heard of. And so you take a lot of time preparing for the anesthetic implications that those provide. So you recommended working in the ICU after graduating nursing. So if you are interested in anesthesia or even some of the like acute care nurse practitioner programs like ICU experience, but if you were trying to go into nurse anesthesia, I would absolutely recommend trying to get into the ICU immediately after nursing school, just to fast track getting into school and being able to apply. I was lucky. I had heard about nurse anesthesia when I was in high school, had kind of set my eyes on it and decided that's what I wanted to do. And that allowed me to prepare myself to like take these next steps, such as getting a job right in the ICU and then going right to school after I had met the minimum requirement. But definitely a lot of my classmates had done a couple years in med surg or the emergency department, some other specialty where they also gained very valuable experience. How do you handle 24-hour shifts? Every single one is different. They're always interesting. You never know what you're going to get. Twice I actually picked up some extra time this week, and twice this week I slept for the full 8 hours at night, which was lovely. And then there's other 24s where I, never even see the call room and you're just in cases and doing stuff all the time. So it just totally, every single one's different. There's no way to really prepare for it, but at the end of the day, it allows me to be home with my kids more, which is, the main reason I do it at this point. But it also is really great experience. I've gotten to do and see a lot of things that I wouldn't have gotten to do if I didn't take call. What is the application process? And when you say after 25, all schools will be doctoral. So basically, probably in about 2017, the schools in Connecticut shifted from master's programs to doctoral programs. So if you're planning on going to school around here, it makes no difference. And all of that, all it really means is that instead of having a master's degree, you now are required to have a doctoral degree. So the programs used to be 27 months, but shifted quite a long time ago to 36 months. The application process, you are required, obviously to have your ICU experience, your RN, your a bachelor's degree. And then some schools require GREs, which are kind of like your SATs for grad school. And then they all require a personal statement, which is, you know, like a short essay explaining why you're passionate about this, why you want to go back to school, why you make a good candidate type of questions. And then the schools will interview you. And then sometimes they bring you back for a second interview, depending on what, you know, what the program is. I hope I answered your question. How do you differentiate between a doctor, physician, doctor, nurse? So clinically, we are not allowed to use our doctoral title. Our doctoral title is in academia. So if I were to teach a nursing course, you know, students would refer to me as doctor. But in the clinical world, we just go by our first names, and nurse anesthetist. This actually has become a whole hot topic, you know, throughout many states as doctorally prepared nurses are, you know, kind of on the rise, with nurse practitioners as well as, you know, other clinical specialties now having doctoral degrees. So clinically, we are not doctors. So I struggled during nursing school. How did you manage studying and preparing during CRNA school? For me, it was a huge thing of time management, especially having kids. So it was just like planning my day out. Sometimes for me, it was getting up early before my kids got up so I could study for an hour. Or, you know, obviously staying up past when they go to bed. So I just found that like having a good planner, and writing out everything I needed to do, checklists, to-do lists, writing all of my assignments so I could kind of see the big picture of what I had going on was really helpful for me. And then also just like setting expectations with myself and my family, in terms of like, hey, I need to do this. I have a big exam coming up. I'm going to need this amount of time to study. You know, can you help me help myself make time for this? Because like I said, you know, support is really, really big during this. You know, my husband helped me tremendously and, you know, picked up the slack in a lot of areas where I couldn't, you know, just didn't have the time. But I would definitely say time management is huge. And I found that making to-do lists and prioritizing things was most helpful. Would ER experience be considered critical care experiences? Most places do not consider emergency department experience the same as critical care experience. They want a true ICU. So they, most schools will not accept ED experience, but there are some throughout the country. I don't know them off the top of my head, but I know that the schools in our area want you to have true ICU experience. I'm just curious, what happened to people who were already practicing with their master's degrees? Nothing. They continue to practice with their master's degrees. They're grandfathered in. There's actually some nurse anesthetists who have been practicing so long that all they have is a certificate. They went, you know, back when the programs were all hospital based and never awarded a degree. They just got a certificate in nurse anesthesia. And again, they're just grandfathered in, like those with master's degrees. I heard the process of getting into a program is competitive and hard. What are your thoughts on this? It's definitely competitive. I think we had about 200 or 300 applicants my year, and my class we accepted 10 people. So it's definitely competitive. My advice to that would be, you know, all of those little things to make yourself stand out. Taking opportunities as nurses to get involved in councils and committees and be influence in your unit, as well as trying to take on really sick patients, get really great experience, and getting, you know, specialty certifications for your unit, like doing renal replacement therapy or you know, if you're a CTICU person, working in cardiac, doing things like, your, you know, ECMO certifications and stuff like that to just make yourself stand out amongst other applicants, Shh. As well as things outside of work. You know, maybe you really want to go on a mission trip that would give you great experience to talk about. Stuff like that can help you know, make up the difference if your grades are you know, just average. So the process is hard, and it's not uncommon for people to not get in the first time and then reapply and be successful. Are nursing students and RNs able to shadow a CRNA? Yeah, so most of the time, once you're an RN, you can shadow a nurse anesthetist in your hospital, which is usually the easiest way to do it. A lot of hospitals, if you just like contact their anesthesia department, they can set you up with somebody to shadow. As well as if you know somebody, they can also help facilitate that. Anybody else have any other questions or comments, or? I hope I answered everybody's questions completely. If there's anything I can clarify, would love to. What's the most difficult case you had? Let's see. I did a really, really interesting case. Probably about, you know, 8 or 9 months ago, and this was a really young guy who came in. He was, I think, in his 30s or 40s, and he was like a laborer. He worked as a landscaper or, you know, some sort of job like that. He had had a couple days of really bad headaches and blurred vision, came into the hospital to get checked out, and his blood pressure was like well into the 200s. That was actually a couple slides back. Let me pull it up. This was the case here. His pressure was 271 over 119 at one point during the case. And we ended up stenting some of his vessels in his brain because as soon as his hypertension was so chronic that as soon as he dropped, you know, pretty much under 180, he started to have symptoms of a stroke or TIA, ischemic stroke. So we had to like you know, keep his blood pressure like well into the 200s. And it was just wild to see a blood pressure like that. And that was this guy's normal. And then recently I did a ruptured aortic aneurysm, which was a really awesome case. The patient actually lived. She did really, really well. And it's just such a rare case to be able to do. So that was probably one of the most fun cases, if you will. Or a couple more. Let's see. Are you standing on your feet the entire surgery? No, we are not. We have chairs. So we're not standing all day, thankfully. If the program doesn't let you work. Yeah, so in terms of financial aid and the program costs, it varies you know, amongst the program you go to in you know, which program you go to. In terms of financial aid, there's lots of financial aid offered for the cost of tuition. And then on top of that, you can apply during grad school, you can apply for something called a Grad Plus loan. And these are loans that you can take out for your living expenses to help, you know, help you just get through that time. So there's definitely lots of financial aid available, and you know, you come out, you make a really nice salary, so you don't really have to, you'll be able to pay back at the end. Do you have to interact with other people in the OR, and what is that like? Yeah, so we communicate with our nurses in the OR, our scrub techs in the OR, and of course our surgeon, pretty much throughout the whole case, throughout the whole day. And most of these interactions are fine. I work at St. Vincent's in Bridgeport, and honestly, all of our surgeons are really nice. There's very few who, are difficult to work with. And so I've had a lot of positive interactions, working with these other people. As in terms of anesthesia, you're kind of the, captain of the ship. If you're having problems with the patient's not doing well, it's your responsibility to speak up, communicate with the surgeon. Sometimes you have to ask a nurse to stop doing something to help you or to do something else that's important for the patient. So we interact constantly all day. What are the math abilities? So getting through school, you do need to, there is some math that goes with it. But in terms of working clinically, honestly, our computers and pumps and everything else do most of the math for us. You program the pump, it gives you the infusion rate and all of that. So not a ton of math involved. So during the program, the requirement is to keep a B or above. If you are not successful in finishing a course with a B, then you unfortunately are removed from the program. The program directors, in my experience, care about you a lot as a person and as a student, and they honestly do everything they can to make sure you're able to meet that requirement, as well as work with the professors for that course to see where you're having trouble, what you need help with, and what they can do to help you finish successfully. What is your favorite part of your job? I honestly, stop it. I love everything about it. I am so fortunate to be in the position I am. I work with a wonderful group. I have a ton of autonomy. I make all of my own decisions. I think critically all day. And then I get to do really fun things. Like I get to go intubate people in the emergency department. We work with fiber optic scopes for difficult intubations. There's a little bit of that thrill seeking, like how ED nurses feel. They love that adrenaline rush. And, sometimes you get that, with some of the things we see. And I, kind of enjoy that part. I do a lot of labor and delivery. And I also love that part. It's, usually very calm and controlled and standard, but being able to help these moms like through something that's really difficult. And you get to kind of bond with these families, because, to some moms you are like their saving grace. And then you go back and check on them a couple days later and you just make a really positive impact on their whole experience. So there's a lot of really cool parts of the job. Yes, honey.
Does anybody else have any other questions or comments that they wanted to add just before we wrapped up tonight's meeting? I'm just checking the chat one more time. Okay, well, thank you so much, Shea. I know a lot, like we asked a lot of the students, like, what kind of guest speakers would you like? And CRNA was like one of the top hits. And I was so glad that like your husband reached out to me to kind of have you come talk to us, because I knew that there were a lot of people interested in hearing more about like your journey and the whole process to becoming a CRNA. So thank you so much.
Awesome. Yeah,
Um,
no, I'm so happy to, have been able to speak to you guys. And like I said, I feel like nobody ever talked to us about nursing school. So I always love to take these opportunities to just kind of spread awareness about what we do and, hopefully interest somebody.
Great. Thank you so much.
Yeah, thank you guys.
All right. Have a good night.
Have a good night.
Bye.